Topic is benign liver lesions, and it's V11. A 60-year-old man is referred to your clinic for the incidental finding of liver cyst on ultrasound scan. How do you manage him? So vast majority of liver cysts are simple epithelial cysts which are benign, have no malignant, but it is important to scrutinize on the ultrasound report what is the size of the cyst, which is the location of the cyst, how the wall looks like, any solid component, any septations, and any solid nodules or increased vascularity. I would also state symptoms related to the cyst. Either it's so cyst can give patient abdominal distension, early satiety, or dyspepsia. However, these symptoms are non-specific. Other common pathology must be ruled out, for example, gallstone disease or gastroesophageal reflux disease and gastritis. So some patients present as a complication which include infection, rupture, hemorrhage. In rare cases, liver cysts may cause compression of the biliary system, portal vein, or hepatic veins. Liver function is usually reserved, but with extensive involvement, congenital polycystic liver disease is occasionally associated with the progressive liver failure, although this is rare. He has a solitary liver cyst measuring 8 centimeters in the left lobe. He reports mild bloatedness after heavy meals. How do you proceed? So first of all, rule out the stomach gastric pathology by doing J endoscopy and also do H pylori, as the symptoms could be from the peptic ulcer disease. If there are no gallstone ultrasound scan and the upper GI endoscopy is normal, if there are no gallstones on the ultrasound and the upper GI endoscopy is normal, I would discuss the role of laparoscopic fenestration of the cyst with the patient. This is provided that the cyst is in an anatomically suitable location. Fenestration would relieve symptoms as well as provide a histological diagnosis, as solitary large cysts may represent biliary cystadenoma, which have potential for malignant transformation. Describe the operative steps. The patient is in supine in reverse Trendelenburg setting. So Trendelenburg in head down, reverse mean head up like thyroid, and 2 to 3 working ports are placed with the exact number. Then I would perform the widest possible excision of the cyst wall back to the interface of the liver, leaving the cyst open to drain interperitoneally. The remaining cyst epithelium is ablated with argon or electrocautery, and I would ensure strict hemostasis and biliostasis. What are the surgical options? Surgical options are full resection of the cyst, but full resections for cyst confined to one segment of the lobe of the liver with suspicious region imaging. The long-term symptom relief is similar to fenestration, but its low recurrence rate and high post-operative morbidity. And liver transplant is the option only in the benign course is drastic, but it only happens when polycystic liver disease. What procedure-specific complications of fenestration do you need to counsel him for? Bleeding, bile leak, recurrence of cyst, worrying histology. What are the other common benign liver lesions are you familiar with? So one is hemangioma. Hemangioma is again from the vessel. So on CT scan delayed phase, it shows a peripheral nodular enhancement with centripetal filling, progressive centripetal filling. And they are usually benign, although large lesions more than located periphery have an increased risk of rupture. And adenoma, again associated with the oral contraceptive pills, and it's a homogeneous enhancement on venous and on returning to near itis density on venous and delayed phase. And these are benign, but there is a small malignant potential as well as the risk of spontaneous rupture. And then it is focal nodular hyperplasia. It looks at circumscribed with hypoattenuating fibrotic central stellate scar on arterial and venous phases, and large central arteries may be seen. The scar can demonstrate enhancement on the delayed phase. These are benign lesions which do not pose the risk of spontaneous rupture. Thank you.